Everyone, and welcome to the new topic called reactive lesions of the oral cavity. So, these are the learning outcomes. By the end of the topic, you should be able to classify reactive lesions of the oral cavity, explain the etiology, clinical, and histopathological features of irritation fibroma, pyogenic granuloma, peripheral giant cell granuloma, peripheral ossifying fibroma, and differentiate reactive lesions based on their history, clinical presentation, and histopathology. Right. So at the outset, I'd like to mention here that the term reactive lesions means any lesions that arise secondary to inflammation. Okay. So moving forward in this lecture, first of all, I'm going to clarify the difference between hyperplastic lesions, neoplastic lesions, all right, and then take you through the various reactive lesions that arise. All right, so what the term reactive and hyperplastic is going to be used here interchangeably. So hyperplastic lesions basically in the oral cavity can arise secondary to inflammation being the cause, and that's why they are also called reactive lesions. Okay, so please don't get confused. If there's any doubts, you can always reach out to me. Okay, thank you. So let's look at the two main terminologies that we will be discussing in this topic. So first of all, the first terminology is hyperplasia. So hyperplasia is an increase in the number of cells in an organ or tissue. Now these cells appear normal under a microscope. They are not cancer, but may become cancer, right? So this is an infographic from Google Images, wherein you can clearly see what is normal cells and how does hyperplasia look. So hyperplasia basically is increase in number of cells in organ or in a tissue, right? So if you've been following the lectures that we have taken in the past, one place where we have used the term hyperplasia is when we have been discussing dysplastic features, and one of the dysplastic features that we have discussed is basilar hyperplasia. So again, there basal cells, which is usually one layer in the epithelium. When there is a double layer, that means when there is an increased number of cells, we call that hyperplasia. So there, in that case, basilar hyperplasia. If this same thing happens in any other organ or tissue, it would be called that hyperplastic tissue. All right. So next is neoplasia. Neoplasia, I'm sure you're all aware, is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissue and persists in the same excessive manner after cessation of the stimuli that evoke the change. Now this is a very standard and a widely used definition of neoplasm, and which clearly explains to us what exactly is neoplasm and how it's different from hyperplasia, right? So what exactly happens in neoplasm is that there is an uncontrolled growth, and this uncontrolled growth continues to take place even after the stimuli uh, that initiated this growth is removed. So that is the difference. So it's uncontrolled growth or an abnormal mass of tissue, right? Whereas hyperplasia is normal uh, looking cells but abnormal number, right? So that's the main difference. Okay, so let's look at EPULIS or EPULIDES. Okay, so as I mentioned, they are localized tumors like gingival enlargements. Okay, they mostly arise from interdental tissue. Etiology is trauma and chronic irritation due to subgingival plaque and calculus. and they are hyperplastic, they are not neoplastic, right? So this is the category which I had just described, right? So let's look at fibrous epulis. So fibrous epulis, as the term goes, okay, is basically a gingival growth which is composed of basically fibrous tissue, all right? So clinically it presents as a nodular growth on the gingiva, okay, which may be pedunculated or sessile. I'm going to explain what pedunculated and sessile is right after on the in the next slide. Okay, these are firm in consistency due to the large amount of collagen. Obviously there's fibrous tissue, fibroblasts produce collagen, and that's why the lesion is firm. They're usually pink color, usually similar to the edges in gingiva, and the surface of the lesion may or may not be ulcerated. Okay, there is a female predilection that has been noticed in fibrous epulis. Right, at what exactly is pedunculated and sessile. Right, now this is and this is a very beautiful diagrammatic representation, an infographic of basically a growth. So if we identify, I mean, imagine this to be let me just get my pointer on. Yeah, if you just imagine this to be mucosa, then a growth like this which has a broad base attached to the mucosa, then that would be sessile growth. Okay, in this case a polyp here. Whereas when you have a polyp that is actually growing out of the mucosa with an attached stalk, something very similar to a bunch of grapes, then you call it pedunculated. All right, so when you compare pedunculated versus sessile, what do they mean? So sessile is when a plant or animal structure attached directly by its base without a stalk, or a pedunculated or a peduncle. But a pedunculated is when there is a peduncle. Okay, the same thing. All right, most of these sessile lesions are flat, whereas pedunculated lesions are mushroom like. Okay, sessile lesions are difficult to diagnose, whereas pedunculated lesions are easy to diagnose as they are raised from the surface. Sessile lesions can be cancerous, and they need to be uh, identified with caution, whereas pedunculated clearly have a low risk, okay, and are surely benign. Okay, so that's the importance of. So fibrous epulis, as I've said, so the term itself clearly tells us epulis means it's on the gingiva, right? And fibrous means there's a lot of fibrous tissue. So histopathology, if you're going to excise this entire lesion, what are you going to see? You're going to see an overlying epithelium, right? Parakeratinized epithelium, because that's the normal epithelium of the gingiva, varying amounts of richly cellular fibroblastic tissue, interlacing bundles of collagen fibers, and variable inflammatory cells. So in this particular slide, what we can see is all this pale pink structure that you're seeing between these cells are basically the collagen fibers. Okay, now sometimes you have fibrous epulis with calcifications. Okay, fibrous epulis with calcifications. So we have so this is a picture to show you that. So basically this is parakeratinized epithelium. So it's again, this lesion is excised from the gingiva. You're seeing proliferation of collagen fibers within the fibrous tissue, but deep down you are seeing irregular trabeculae of woven bone. Okay, showing osteocytes with lacunae and lined osteoblasts. Okay, so these are called fibrous epulis with calcifications, or the other term that is also used to describe them is peripheral ossifying fibromas. Okay, so both terms are interchangeable. Okay, now the treatment for these lesions, okay, is surgical excision of the growth and oral prophylaxis. So oral prophylaxis is something very important because the etiology for most of these lesions is calculus and plaque, right? So unless we remove the calculus and plaque, these lesions will recur, right? So to achieve good prognosis, it's very important to excise the lesion, and before excising the lesion, you actually do oral prophylaxis. Yeah, so that's the other term called peripheral ossifying fibroma. I'm sorry, proliferation of endothelial cells in sheets of budding. Numerous plump endothelial cells are seen, and there is a fibrostroma with varying degrees of inflammation. Right, so this is the histopathology. So you're seeing the overlying epithelium here. This area here is ulcerated. Okay, how do I know this is ulcerated? Because you're not seeing the epithelium with the dirty pegs over here, but dense inflammatory cells. Other than that, all these white spaces that you're seeing correlate to high power view of the vascular spaces. Okay, and the blue dots that we see are the inflammatory cells. So what is the treatment? Again, the treatment is surgical excision of the growth and oral prophylaxis to remove the irritating factor and prevent the recurrence. Okay, so let's look at giant cell epulis or peripheral giant cell granuloma. First of all, the etiology is unknown. Okay, it's been attributed to irritation due to, again, plaque and calculus, or poorly done dental restorations which have overhangs or have sharp edges or an ill-fitting appliance. It can occur at any age. It's common in females. Usually the lesion is asymptomatic and rapidly growing. So it occurs on the gingiva. It may be pedunculate or sessile. You know that. Dark red, vascular or hemorrhagic. So this is a case here wherein there is an interdental, there is a growth on the gingiva, okay, interdentally in mandibular anterior region, okay. Uh, this lesion actually turned out to be peripheral giant cell granuloma, okay. So basically it's a histopathologically what we see is a non-encapsulated mass composed of reticular and fibrillar connective tissue, multiple multinucleated giant cells. This is what is pathognomic here: dilated capillaries, foci of hemorrhage, hemosiderin, and giant cells which have been proved to be. So this is how it looks. Again, we're able to see the epithelium here. We're able to see these giant cells. Okay, these are the giant cells that we're talking about. Under high power view, this is how they look. This is hemosiderin, the brown color pigmentation, that pigment that is seen here in the connective tissue. These red structures that you're seeing are extravasated RBCs, and this is how peripheral giant cell granuloma looks, right? The treatment is the same, right? So that's the arrow that shows us the giant cell. So the treatment is again similar to all the other epulis: surgical excision of the nodular growth down till the periosteum to prevent recurrence, and oral prophylaxis to remove the etiological factors or the irritation factors which are actually leading to this hyperplastic growth, right? Okay, so moving on, the next lesion is fibroepithelial polyp, and these are common oral lesions that occur on wide age range. Okay, they commonly occur along the occlusal line. Okay, these are growths, hyperplastic growths along the occlusal line, which commonly occur due to trauma or irritation. Okay, so commonly seen on the buccal mucosa. They are painless, firm, pink, pedunculated or sessile swellings, right, similar to this that you can see here. So the etiological factor here in this particular case could be this sharp edge of this decayed tooth, which could be where the patient actually is chronically cheek biting, and it's led to this hypoplastic lesion. Right, so what happens when we actually excise this lesion? What do we see microscopically? Well, we see dense acellular fibrous tissue, right? Something like scar tissue, thick interlacing bundles of collagen fibers. Fibroblasts are scant, although plump and angular, and the overlying epithelium may show atrophic changes, right? So this is where there's atrophic changes here, but in this slide here, the epithelium is normal. You're seeing a large amount of fibroblasts and collagen bundles in the slide. So again, this is a hyperplastic lesion, okay, commonly secondary to trauma and irritation along the occlusal line. Okay, so the treatment is surgical excision and removing of the causative factor. Okay, so here in this case would be the sharp edge of the tooth. Okay, so if a lesion, a fibroepithelial polyp, actually occurs under a denture-bearing area, commonly on the palate of a denture user, then it is described, it presents itself as a leaf-like fibroepithelial polyp, okay, and it's actually called a leaf-like denture fibroma, okay. This is again due to chronic irritation of the denture, and this is a hypoplastic lesion, and shows no malignant transformation, and is because of trauma and irritation. Okay, right. So the other lesion is denture irritation hyperplasia or denture induced hyperplasia. Okay, so these are hyperplastic mucosal overgrowths that are associated with ill-fitting dentures, right? and they present as firm leaf-like swellings, usually on the labial and the vestibular sulci embracing the denture flanges, right? So here in this case, as you're seeing, you are able to see this leaf-like folds of tissues in the vestibule, right? Here in this, the maxillary vestibule, here in the mandibular lower vestibule here, okay? So they're also called Epulis fissuratum, okay? They are hyperplastic tissue, as outlined previously. They're firm in consistency, commonly seen in the mandibles in females, and the growth embraces the overextended flange of the denture. So again, the etiology is associated with ill-fitting denture. So what we need to do here is to remake the denture and first of all excise this lesion, allow the lesion to heal, and then redo the denture of these. Okay, lastly, the lesion that we are going to discuss is called papillary hyperplasia of the palate. Okay, so this is the clinical presentation of papillary hyperplasia of the palate. Okay, so this condition presents on the hard palate, usually seen in the middle-aged to elderly female patients, almost invariably under an ill-fitting upper denture. Okay, so it's usually seen in the palate. The exact etiology is not known, but it is thought that chronic trauma from a rocking denture predisposes to this development of these lesions. Patients usually give a history of wearing the prosthesis while sleeping, and clinically there are multiple pinpoint projections on the anterior hard palate, okay, which is what we can see in this clinical picture, right? And this hyperplastic lesion is frequently associated with candidal overgrowth, right? With candidal overgrowth. So these lesions present as or present in association with candida, and thus the treatment that is done here in this particular patient is basically the patient is advised to remove the dental appliance at night and to practice appropriate oral and denture hygiene measures, and topical fungal therapy is used to treat the underlying candidal infection. And of course the surgical excision of this papillary lesion is done, and then the fabrication can be done. Okay, so if we actually excise, when we excise this lesion and send it for to the lab, what we actually see are numerous papillary projections, each comprising of a core of hyperplastic chronically inflamed granulation tissue, right? So this is the papillary projection, this is the core of chronically inflamed granulation tissue, and these are lined by stratified squamous epithelium, which you can see here, right? And we see something called as pseudoepitheliomatous hyperplasia, which is what you see over here, right? And obviously heavy chronic inflammation secondary to the trauma that is being caused by the ill-fitting denture, right? So this brings us to the end of the my lecture on hyperplastic lesions of the oral cavity. Thank you.